So good. Well, I would say let's get started because all of our time is valuable and we're past the hour now. Actually, well, we've crossed 111, but let me at least start by welcoming people. And because we have a fairly full schedule here, Dr. Hornefer and Dr. Hirumi will have many ideas, concepts, and things to share with you. So it's my honor to kick us off again. Welcome to this second webinar in this 3-webinar series. I warned at the beginning of the first one that you may leave slightly unfulfilled and that would be by design. So that might be the case again today. But hopefully you will feel nourished and stimulated and triggered to reflect and hopefully take away some practical things for your teaching or teaching strategies as you think about them, given that a lot of them are changing and adapting right now to the new realities. We looked at your feedback. One of the key things from the last week that people highlighted there, the evidence-based medical education part was really a key aspect for them. You're welcome to review the recording from last time in case you haven't. It should have gone to all of you with the invitation reminder for this session. So we'll be building on that today. One of the requests there was also changing the classroom was a key aspect in the survey where people wanted to take action going forward. And so flipping the classroom will be something we will discuss in the next webinar. And we will make that actually a flipped webinar. So we'll talk about flipped classroom in a flipped webinar format. So at the end of this, we will tell you how that works because we want to put what we talk about into practice. And we'll talk a bit more about the design of these different sessions and their different functions as we go along. Timo, if you could please, my dear colleague Timo, who travels the world with me and is one of our education experts, is kindly offering his technical skills as services here to move us through. So Timo, you can move to the next slide, please. So here you can see a little bit these numbers. If you remember them from last time, they've gone up. So the interest is increasing, which is great. We had a very engaging session last week. Feel free to share the idea of joining the next webinar with colleagues, and obviously you can share the recording as well. But so you can see you come from all over the world really here. Obviously the time zones, US and Europe, broadly speaking, are somewhat advantaged here. So in Asia, it would be a little tough to be up at this time of night. So during the webinar, feel free to post questions in the chat function. We'll be sort of going through, in terms of roles, by the way, you can see here, we have a lot of senior educators and instructional experts with us today. And so we look forward to engaging with you. And in terms of engaging, I was about to say you can post your questions in the chat function as we go through. We will compile them and so on so we can discuss them at the end. So we want to make sure we actually have some time to talk to you as well. And so, but please hold your questions until the end in terms of unmuting yourself and so on. We'll do that at the very end. So with that, let me introduce our two speakers for today. Dr. Hornefer, a Hopkins-trained cardiac surgeon living in Maryland. Dr. Hornefer has an interesting educational history. He got the first medical school in the world accredited that was teaching the first 2 years online. This was in a remote island in the Pacific. And this was as early as 2008. I think few people can claim to have been as online as he has been for as long, at least. He's also director of medical education here at Lecturio, something we're very proud of. Dr. Hirumi, our invited speaker today, works at the Department of Learning Sciences in the College of Community Innovation and Education, and also at the Department of Medical Education in the College of Medicine at UC Florida. Dr. Hirumi, expert who over 25 years has researched, designed hybrid learning experiences, is widely published, has worked across various fields and geographies literally around the world, holds 3 awards, including from the Association of Educational Communication Technology, from the US Army, and from the Texas Distance Learning Association, amongst others. And so with that, let me hand it over to Dr. Hornefer.
Thank you, Stefan. And I really only have to disclose the three professional existences I have now. One, I'm presently Executive Dean of the All-American Institute of Medical Sciences in Jamaica, which is much like my South Pacific endeavor. It's an effort to bring medical education to an underserved area. As Stefan mentioned, also serve as Director of Medical Education Programs at Lecturio, and remain a cardiac surgeon, though I am working hard on focusing on these first two professional endeavors as they are very exciting and captivating. And all three of these, fortunately, coexist and support each other very well. Tusi, any disclosures from your standpoint?
Thanks, Peter, and thanks, Stefan. I do want to disclose that I am conducting a series of research studies currently on the students' use of commercial learning platforms. I'm also a strong advocate of commercial partnerships and the integration of learning platforms, but I am not under any contractual agreement with any companies at this time, nor am I promoting or endorsing the use of any particular platform, including Lecturio. Peter?
Right, so thank you, Tusi. And I also wanted to thank all our participants again for coming out. It's really been overwhelming from our standpoint. What Tusi and I are talking about is a subject which is very of great interest to us and dear to our hearts, and we've both been working at for a number of years. But seeing the overwhelming number of registrants and participants, and the fact that you've all come back for the second go-round, I greatly appreciate. I just want to recap briefly that last week we described what we call emergency remote teaching. It's essentially the current reality. And what most schools have done post-COVID-19 is reproduce standard teaching practices, but simply in a remote fashion. And while many have found aspects of this new reality to offer advantages, most have also found it lacking. So we spent our time last week focusing on how to seize this opportunity of forced change and making this change long-lasting and for the better. We discussed why we should evolve from emergency remote teaching to what I call highly effective evidence-based education. And the key to making this transition was the use of instructional designers and learning platforms. So Tusi, do you want to recap the instructor designer role?
Sure. Very quickly, during webinar 1, I delved into how instructional designers may be strategically integrated into medical education to facilitate evidence-based medical education. Specifically, I talked about how instructional designers may help med-ed faculty during each of the 5 steps we propose for facilitating evidence-based medical education. During this session, I hope you will all see how instructional designers may greatly facilitate the transition from teacher-directed methods to more student-centered learning. Peter, I also thought that you had some great ideas on how learning platforms may be used to facilitate evidence-based medical education. Do you have some ideas on how platforms may be used to promote active learning as well?
Yeah, absolutely, Tusi. And platforms can be especially helpful when trying to promote this student-centered learning. And we're going to go over that today. Before we move on, though, I want to emphasize that in addition to the advantages listed on this slide that we went over last week, platforms also play a crucial role in making teaching more efficient and affordable. By having content reside on a collectively built platform, each individual school can build from there and doesn't need to reinvent the wheel each time a subject is taught or a school is created. It also allows content to be delivered to more remote areas, such as my school in Jamaica, the All-American Institute of Medical Sciences, or AIMS. And it's interesting to note how businesses have adopted modern, efficient methods far more readily than schools. Think of how manufacturing has evolved over the last few centuries. And in contrast, the way education has been delivered has actually changed relatively little over the last 2,000 years until the last couple of months. So in this slide, you have a depiction of Hippocrates teaching on the left. On the right is the lecture hall, and that's where I actually attended my med school classes when I was at Hopkins. And until COVID-19, the scene at the bottom was pretty commonplace. So the question is, will COVID-19 put an end to this form of teaching forever? I suspect that large lectures are going to become quite rare in the post-COVID-19 era, as we now have far more effective ways to learn. So Tusi, let me ask you, other than not being able to socially distance in crowded lecture halls, what's wrong with this method of teaching?
Well, Peter, I wouldn't say it's necessarily wrong, but it's kind of limited, I think, online. So teacher-directed methods and materials, things like PowerPoints and text-based materials, really focus on the transmission of information. The instructor has all this knowledge in his or her head and wants to transmit it to a group of students who are all learning at the same time at the same place. Teacher-directed methods have limited interactions that often results in feelings of isolation and anonymity. They also lack interactions that are really necessary to interpret and construct knowledge. I would say teacher-directed methods have an inordinate use of very precious synchronous time together with students. If you think about it, teacher-directed methods is also based on speaking and listening. So when we're teaching in class, the predominant media or the predominant way people learn is from speaking and listening. But online, the predominant way people learn is through reading and writing. So it's not necessarily engaging. It really depends on the instructor. So I would argue that teacher-directed methods in general fail to use the potential of interactive technology to facilitate learning. I really like this quote. Without interaction, instruction may simply become the passing on content as if it were the dogmatic truth, and the cycle of knowledge acquisition, critical evaluation, and knowledge validation that is important for the development of higher order thinking skills is non-existent. I really feel that that quote right there captures everything.
It's a really good point too, C. And interactions are vital for the development of critical thinking. So Tusi, what kind of interactions are effective?
Well, that's a great question. Before we really get into it, I want to start by asking another question, something a little bit more fundamental. What do you think is the difference between information and education?
So information is something I think you read or hear, and education is more something you experience and learn from so that you can apply it.
Very good. What else? What is the difference between going to a movie or going to a concert, reading a book, or going to, let's say, one of your classes?
Well, I think the key is that classes can allow for interactivity.
Precisely. So would you say that education consists of a series of events and interactions necessary to facilitate learning?
I always agree with the teacher.
Very good. Well, I like to say that information is either audio, video, text, or graphics designed specifically to transmit a message from the sender to receiver, where education really consists of a series of events and activities intentionally designed to facilitate learning. So a little bit more deeper, can we go to the next question? What do you think, Peter, is the difference between what I would call craft-based or the subject matter expert approach to design versus systematic design?
So I think you're asking me the difference between how things have always been done and how they should be done. Is that correct?
That's pretty good, Peter. I define craft-based and the subject matter expert approach as when the events and activities that are designed to facilitate learning are based on past practices, opinions, fads, and politics, really the N of one. You know, I see so many teachers when I ask them, why did you design the lesson the way you did? It's because that's the way they learned. And if I learned that way, why wouldn't everybody else learn? I would call that craft-based. Where systematic design, those series of events and activities that are designed to facilitate learning is based still on practical experience, which is still very important, but also based on research and theory.
So, Tusi, what role should faculty and staff play in an educational world based on evidence?
Well, in my opinion, to realize the opportunities that are afforded by COVID-19 to advance education, I believe that a greater number of medical educators should embrace and facilitate active student-centered learning. So here's a diagram. Oh, go ahead.
Yeah, no, I was just going to say that, you know, some medical schools are already working towards promoting student-centered active learning and an integrated curriculum, and we're doing this before the pandemic. So how would we build on this now?
You know, you are right, Peter. Problem-based learning is not new, and it is a student-centered paradigm. Medical schools have been applying problem-based learning ever since Burroughs formulated the approach back in the 1980s. But many student-centered active learning tactics and strategies have been developed since then. Fundamentally, student-centered learning differs from teacher-directed methods in many ways. I think this diagram captures it fairly well. If you look at teacher-directed methods on your right side, before you go there, Timo, do you want to go back to this first slide? Sorry, yeah, thanks. So if you look at, the next one. Okay, if you look at the diagram for teacher-directed learning, you see all the knowledge and information is in the teacher's head, and he or she transmits that to a class of students that are, again, learning at the same rate and at the same time. In the student-centered paradigm, we have individuals and small groups of collaborating students. They have direct access to the knowledge base, and the teacher is like the guide on the side, the facilitator who helps the student interpret and apply information. And now we bring people in the community, other experts, other people, maybe even patients, who are actually an integral part of that student-centered environment. To give you some more details, now Timo, could you click on that table? Like we did in that first webinar, I like to give out a lot of handouts that provide more detail, but you can look at all this later, right? So just so you see what I have as a first handout, I use this in many of my workshops. If you scroll down a little bit, the table, there's the diagram, and a little bit lower in the table, table 1, it really gets into very specific instructional variables within a learning environment and compares teacher-directed versus student-centered learning. But again, a lot more details that you can look over after this webinar. And again, if you have any questions, please feel free to contact us. So let's just go back to the diagram. Okay, so that's some specifics about it. Now, there's a lot of tactics as well that have been developed, as well as models for facilitating student-centered learning. So you might have seen some of these tactics being presented or posed in other forums. Timo, would you click on the tactics? Very good. Scroll up. Okay. So here's some models of learner engagement and active learning that I think are useful for explaining and predicting engagement or learner engagement within instructional environments. So the first one, you have flow theory that suggests that learners are engaged. It depends on how difficult the task is and how skillful the individual is. So I think that's a useful way of looking at learner engagement. Another way is just learner engagement models themselves, which suggests that you have to look at both how engaging the learning resource is through the use of multimedia, for example, as well as the learning task. The third model that I think is particularly useful to consider when you talk about learner engagement, interactivity, and student-centered learning is this whole traditional Yerkes inverted U. So it's important to remember that there's an optimal sweet spot in between. If the stimulus is too low, performance is low. If the stimulus is too high, performance, again, goes down. It's like confidence. If someone has very little confidence, their performance is low. But again, if they're overconfident, often their performance will go down. So I think these are important concepts and models to consider. But again, I provided you with some resources and some references to go into it further. If you keep scrolling down, Timo. I also have listed here some interactivities or specific learning tactics that have been presented or proposed by different models. Here's the 5E instructional model that suggests a bunch of different interactivities or active learning experiences, demonstrations, observing natural event, all a nice list that could help maybe give you some ideas on how to make learning more active. From the ARCS motivational design model by Keller, here's another series of tactics for making learning more engaging and more interactive. I also listed a bunch of interactive techniques that have been compiled by Yi. And again, I give you some references, but again, these are a bunch of resources that I like to give out during workshops and in my class that might give you some ideas of how to stimulate active student-centered learning. Okay, get the next one. I also have one more handout that really focuses on strategies for facilitating active student-centered learning. Now, strategies differ from tactics. Tactics are individual events and activities that are designed to facilitate active learning. Strategies is a comprehensive set, in my opinion, of these events and activities. If you remember back, we defined education or distinguished education from information as a series of events and activities designed specifically to facilitate learning. So if we look at some of the strategies, this is actually the #1 handout that people request after I do workshops and presentations that I utilize in my class as well. I've compiled here a bunch of different instructional strategies that are all based on learning theories and different instructional theories and design models. I start off with a series of experiential learning strategies. If you're into experiential learning, you've probably heard of Cobb. Richard Clark has a guided experiential learning model. I love learning by doing because it's story-based. Most of you have heard of problem-based learning with Burroughs, collaborative problem-based learning. One of my colleagues that unfortunately has passed recently did a lot of research on problem solving and how if you teaching people how to solve different types of problems, you really have to design your environment to match that type of problem. So again, design is really based on what you're trying to teach. So here's some different problem solving techniques. Scrolling down a little bit further. So here are some more learner-centered approaches. We've done these already. Keep going down. Okay, here we go. The 5E model, that's actually the model that we use to design the webinar for the third webinar that we facilitated next week. The 5E model is based on a biology group, and now it's adopted by the National Science Foundation as a way of really facilitating science learning, which is based on the brain's or people's natural way of inquiry, where you engage, explore, explain, elaborate, and evaluate. So again, a whole series of different instructional strategies. If you keep scrolling down, historical inquiry model from social sciences. I love that one. Oh, and here's a group of teacher-directed methods. So remember, I talked about teacher-directed methods, not necessarily bad, just limited in terms of their methods. But here's some traditional teacher-directed paradigms. 9 events of instruction, very famous, Gagne's 9 events. The elements of lesson design that was taught to teachers in K-12 education for decades in the US. Going further down, many of you may have heard of neurobiological studies of human learning now. And we have things like brain rules and brain-based teaching. I have been fostering the development of this interplay instructional strategy for the last 5-10 years. That's based on actually some game-based principles and storytelling. So again, not to go over this in too much detail now, but hopefully as a resource that will help you over time. If you're thinking of moving from a teacher-directed approach and you're looking for ideas on how to facilitate student learning or student-centered learning, here are a variety of instructional strategies that are based on that theoretical approach.
So, Tusi, wow, that is amazing. You know, frankly, it's almost overwhelming. I didn't realize there were so many different instructional strategies. And so can you tell us how best do you apply these?
That's also a good question. So it really isn't that involved. This is kind of a template that I use in my classes and again in workshops where I have people fill out these 3 columns. And again, a good active way, an authentic way of applying student-centered learning is to redesign an instructional unit. So what I do is I get people to identify a lesson that they want to redesign using the student-centered methods. And then I get them to fill out what I call a sample instructional treatment plan, a glorified lesson plan, if you will. So in the first column, if you click on it, after you think about your lesson, what you want to do, then you look at all those different strategies and I work people through those strategies. Why would you use one versus another? And then they select a strategy based on their desired learning outcome, their values and beliefs, their own educational philosophy, and they pick a strategy. So in this example, they've picked guided experiential learning. So there's 6 different events associated with the guided experiential learning model. And I have the workshop participant or the student fill out column number 1 with the different events associated with that instructional strategy. And then I give them some time to fill out column number 2. So here's an example of how someone might fill out column number 2. Not a lot of details at this point. It's a very high-level design document. But you can see in this example, they are distinguishing what is done synchronously and asynchronously to facilitate each of the instructional events. So this is a systematic way of designing blended or flipped classroom instruction. You don't have to do synchronous and asynchronous. It could be all synchronous, and this could be used in a traditional classroom environment. It could be all asynchronous and totally self-instructional online. I'm just illustrating that it's at this point you can make certain design decisions and systematically figure out what to put online and what to do face-to-face. So again, you're just summarizing very quickly how you would facilitate each of the events that are associated with the instructional strategy that you've selected for your lesson. Now the third column gets more into the technical features. When do you use chat? When do you use email? When do you use the learning management system? When do you facilitate things face-to-face? When do you use Zoom? So before, people just throw these things out because they know it's important, but it wasn't based on any kind of pedagogical rationale or reasoning. Now we're making decisions in terms of what tools to use when, based on your instructional strategy. So in the third column, tools, you're describing or listing the tools that you would use to facilitate each of the interactions listed in column 2, which is then used to facilitate each of the events listed in column 1. You know, it might seem a little bit involved, but honestly, now after doing this for so many years, or I think everyone here would find after a week or two, or a couple of times of doing this, this really takes you maybe an hour or two, maybe a little bit more to do a lesson. So now you have a good roadmap of how you would facilitate, in this case, a guided experiential learning lesson. And then you could work with your team of designers, you could work with your multimedia experts, or you could just take this treatment plan and bring it to your class and use it to follow as a lesson plan.
Tusi, this is all a tremendous amount of great information, and you really see how important instructional designers are in this process. But I'm going to take a minute now and go through, and Timo, we can get the next slide. So a few points on how platforms also can actually build in and create a climate which mandates interactivity. Is a great example in this COVID era, as we were recently asked at Lecturio to create an interactive learning tool for students and residents that needed to learn new protocols and procedures, which were uniquely applicable to COVID-19 patients, so that these patients would get optimal care and the caregivers would remain safe. There are a lot of unique features to the treatment of COVID-19. This is also a great example of what we talked about last week when we described the new approach to education relying on teams to create solutions. So in this particular case, we were approached by faculty at Hopkins that saw the need, but their institution didn't have the resources or expertise to carry it out in a timely fashion. And Lecturio had the software, graphics, and production expertise. And I, as an educator and director at Lecturio, was able to coordinate the effort. So within a few short weeks, we'd completed a prototype, and that was soon followed by 4 more cases. Moving almost as fast as COVID-19, which is moving pretty quickly, we created what I think is a crucially important educational product that had been made available for free and is being used by hospitals and medical schools globally and is completely interactive. And I'm just going to take a minute now and take you through just what this looks like. It is sort of a moving interactive thing, but to illustrate, you get a selection of cases that you can pick from. You then get background on each case with its associated learning objectives. The case is then outlined, much as in a clinical presentation. You get the history. And then you're able to describe important procedures. In this case, what you see illustrated is what's called the RUSH exam, which is short for rapid ultrasound for shock and hypotension, something commonly used on the more ill COVID patients. You then have to interactively use mix and match or other types of branching decisions to ensure that you've understood the concept. And if you make a mistake, you're directed to try again. And what's great about this is you actually have to complete a given exercise successfully in order to proceed. And then at the end, you get much as many of our designed educational experiences, you get recall questions that test your comprehension. And crucially, these recall questions are then added to the platform's spaced repetition engine, which, as we discussed last week, augments long-term retention. Another excellent way to create interactivity is to use patient simulations. And so these have been around for a while, but for those that don't have the substantial costs, often $1 million or $2 required to purchase the interactive mannequins, or who want to make it available to their students wherever they may be, this kind of modality is now built into the platform as well. You can ask questions and get responses from this mannequin. You can do exams, order tests. You're evaluated on your performance, and it's all timed in a real-time fashion. So it simulates a clinical interaction in a very interactive way. So, Tusi, is active student-centered learning always the best way to facilitate learning? Now, I believe there may be times that you mentioned that teacher-directed methods are still useful.
That's a really good point, Peter, and an important one to make, really. I know very few things in this world are right all the time, right? So one of the principles of instructional design that I really try to emphasize when I'm working with educators as well as training instructional designers is that the design of your instruction should be based on your desired learning outcome. So we have 50 to 100 years of research that tells us that how you design a lesson to teach someone problem solving should be different than a lesson where you're trying to teach someone a procedure or teach someone some facts, or maybe even try to change their attitude. So we have a lot of research that says that design should be differ based on the desired learning outcome. So that's why it's important to understand a learning taxonomy. So I created this chart, this table that compares some very popular learning taxonomies. So on the far side, you see the very traditional tripartite model, which was actually developed a long time ago. Hilgard just did a nice summary of the history of this tripartite model that says there's three fundamental domains of learning: the cognitive domain, the affective domain, and the psychomotor domain. And you see there's a lot of research on the cognitive domain and the different levels of learning within that. Many of you are probably familiar with Bloom's taxonomy. I was privileged enough to learn under Bob Gagne, and I always use Gagne's taxonomy. But I also like the revised Bloom's taxonomy by Anderson and Croftball because it really distinguishes create or creativity as a learned outcome. Again, Anderson comes from medicine and neuroscience. We got Miller, who is very popular in medical education as far as designing different types of assessments and learning outcomes. But the point here again is that depending on what you're trying to teach, what your learning objectives are, you use different instructional methods. So in general, if I was teaching people some facts or a very simple procedure, which is still very important in many areas, I would use a teacher-directed approach. Next one. Okay. But then if I'm trying to teach people some higher order thinking skills, problem solving, cognitive strategies, analysis, evaluation, things where there's multiple correct answers or multiple ways of deriving the answer, then the student-centered approach becomes very important because students work with other students and the instructor is facilitating students' interpretation and application of information that differs based on context and many other variables. So like you had imposed originally, when do I do student-centered? When do I do teacher-directed? I would say based on the desired learning outcome. So that kind of leads me to more of the blended learning solutions. Next slide, please. So we've been studying blended learning for, probably 20 years or so. This example comes from a study I did with the Army Intelligence at Fort Huachuca in the US on blended learning. In their situation, they moved to blended learning to optimize class time in the schoolhouses. Soldiers were being sent out into the field faster, but had to know more in less amount of time. So the problem was, at that time, there was no concrete guidelines or formulas to determine what aspects of a course to put online, what aspects of the course to facilitate face-to-face. So myself, I led a team of instructional designers, and we looked at and analyzed a bunch of training that was being offered by Fort Huachuca Army Intelligence and came up with some basic algorithms to determine which aspects of training to put online and do asynchronously versus what to do face-to-face and do synchronously. So just real short, we've decided that things that are really stable, content that is really stable, that focuses on some of the lower order learning objectives, things like facts, concepts, straightforward procedures, where there's just basically one way of doing things properly, lends itself to an asynchronous environment. Things that you could do online very rapidly and very effectively. Where again, the more higher order thinking skills, as well as very dynamic content, things that change rapidly, things that were happening out in the field, in the military at that time, that, you know, the next week they had to come up with different approaches because they were learning things specifically in the Middle East and other places that they had to change their training very rapidly. So we decided those were the things to do synchronously. Of course, the actual algorithms we came up with is a lot more involved than that, but that's some of the basics. I do have a lot more concrete examples, but they're classified. But Peter, you probably have some good examples of this from the medical area.
Yeah, and you know, I think medicine is a great example of a large body of information, especially in the basic sciences, where there's a very stable, large knowledge base. Anatomy is anatomy, and though it's been evolved in how it's presented, much of what students need to learn in the early years has changed very little. So you'll see as we go to the next slide, Timo, blended learning environments, however, don't necessarily mean that they're flipped. And I think we should spend this last section of the webinar today on this concept of the flipped classroom, because many of us in medical education are hearing about it, talking about it, and are familiar, but some applying it more than others. And I'm working on this with my school in Jamaica to have a more wide adoption of a flipped classroom. Careful introduction of this method is really important in terms of getting adoption, because most faculty and students haven't been exposed to this before. So in my experience, it's been very helpful to have a well-developed learning platform in place to facilitate this approach to teaching. You need to have both a complete library of recorded materials, but also the ability to easily add customized materials, because every school has its unique elements that they want to include, and many faculty simply prefer using their own material. Having said that, a library of pre-recorded lectures by high-quality teachers is invaluable. I started my school in the South Pacific. We didn't have that, and it's been a great help at Ames in Jamaica. And remember also broadly, you know, not all faculty are suited to teach. And this was true of my experiences as a student at Hopkins and everywhere. What platforms allow you to do is to choose from the best and make them widely available. The other great advantage to platforms, as we talked about last week, is good data tracking and analysis. You want to make sure your students are remaining on track and are preparing as they are supposed to. You'll see in the next slide the detailed analytics these platforms can get, and this is just an overall view, but you can get drilled down into what questions students are answering correctly and incorrectly, so that when a teacher arrives at a class in a flipped environment, they already know what concepts need to be emphasized and what students are struggling with. So this can really greatly facilitate the introduction of a flipped classroom, and can be done over a period of time. You don't need to apply everything all at once. So in addition to a good teaching and learning platform too, so do you have any suggestions how medical educators could facilitate the adoption of this approach?
Yes, certainly. This is one of the challenges, is you have to know it, but you also have to have the right conditions to facilitate it. So there are a number of concepts that I think are useful to keep in mind, and ideas from research and literature and human performance and change management. They may help people, especially administrators, but also educators, adopt and facilitate the use of these active student-centered methods. One of them is just this basic formula. Performance is a function of people's skills and knowledge, their motivation and opportunity. So depending on whether they have the skills and knowledge, whether they're motivated, and they have to have the opportunity, have the tools, the time, the policies, and other resources necessary, in this case, to facilitate student-centered learning. I also like the next set of factors. If you look at the research on the diffusion of innovations by Ev Rogers, he came up with 6 different factors of innovations that affect its adoptions. Its relative advantage. Is student-centered learning better than the idea, practice, or object is superseded? Compatibility. Is it consistent with existing values, past experiences? How complex is it? Is it simple or too complex to adopt? How trialable? Can someone just try a small piece rather than adopting the whole innovation? Modifiability. To what extent can the person adopting the innovation modify something to meet their individual and unique needs and interests? And observability. Will the results of the innovation be visible to others? So another useful set of concepts, I think, to help you facilitate the use of any innovation, but active student-centered learning in particular. If you go to the next slide, we have Keller's ARCS model of motivation design. This is near and dear to me because John Keller was actually my major professor when I was doing my doctorate work at Florida State University. And he's famous for the ARCS model. So if you know theories of human motivation, there are hundreds. So what do you do with hundreds of different theories of human motivation? He's famous for synthesizing all those different theories into 4 basic constructs. So if you go through some exercise, if we had more times, I'd have you think about all these different things that motivate you or demotivate you, and all of them fall under, typically, one of these 4 constructs. So the ARCS model suggests that to gain and sustain learners' attention, or to motivate students, you have to gain and sustain their attention. In order to motivate students, or in this case, in order to motivate faculty, to use student-centered active learning principles, it's got to be relevant to one of their needs. You also have to promote confidence in the learner's ability to succeed. And that learner has to be satisfied that it was worth their time and effort. So this is a meta theory that subsumes all these other theories of human motivation. I presented you with one formula that suggests motivation is part of the key. But we all know that you could sit there and lecture and have the greatest content in the world. If the students aren't motivated, or if the teacher isn't motivated, they're not going to apply the innovation. So the last slide I kind of want to mention that I think is useful is the notion that you have to protect innovations. So let's say you want to adopt more active student-centered learning approaches or any innovation. We know that innovations take time. 3 to 5 years to mature and become truly effective and reach potential. We have to protect these ideas from normal pressures of day in and day out instruction and education. We have to let that innovation spawn or become successful, enabling small groups and small successes, and then build the infrastructure while you're doing this innovation to support and align all these different components that are necessary to facilitate the innovation. So that's kind of a quick summary of some of the key concepts that I've taken over time to facilitate change in human performance. That's also very important in addition to instructional design.
Wow, Tusi, we really covered a lot of ground. So in summary, go ahead.
Yeah, we did cover a lot of ground, Peter. Yeah, I started talking first about teacher-directed and student-centered learning and comparing the two. I also discussed the difference between craft-based versus systematic instructional design. Also had a handout about different tactics and strategies for facilitating active student-centered learning. I also illustrated how a faculty member could use an instructional treatment plan to apply and facilitate active student-centered learning.
Yeah, and we also looked at how learning platforms could facilitate interactive learning, compared blended and flipped approaches, and again, how learning platforms can facilitate this blended learning environment in the flipped environment. So we did a whirlwind tour. We're going to go now, as we did last week, to polling questions, so we can ask our participants some questions just to get your reflection, and then we'll move and we'll tell you a little bit about next week, because I think it'll be both challenging and exciting. We're going to try and put all this to work. But first, for the polling questions, so to what extent does your school use a student-centered structure for learning? And that question should pop up, and please just answer.
Yeah, so I unfortunately have bad news on that front. I'm getting an error message for the polling questions. It says I'm not logged in, but I mean, I'm here. So
You're here, Timo. Well, so let's do this. We're going to send you the polling questions, and actually we've used a little bit more time because we do want to answer your questions. So it's actually fortuitous. You see the polling questions here. We're going to send those afterwards, and then you can just answer, but trying to get an idea of how many of you use a student-centric structure, how many of your faculty use a flipped classroom approach, and to what extent you think medical education could be conducted or should be conducted in a flipped or a blended fashion. So you'll get that in the follow-up. I also want, as we did, if we can go to the next slide, the reflections, and these are broader based, but we're going to ask you to take some time and think, what do you believe medical education will look like in 5 to 10 years? And as importantly, what do you think it should look like? I have to say that when we originally started putting this together, we used the 20-year timeline, and post-COVID-19, I think all our clocks have been greatly accelerated, and we thought, I'm not sure what things are going to look like in 6 months. So 5 to 10 years is probably a pretty generous timeline. So then let's talk about next week, because I think we're really excited about what we're going to do for next week. Several folks commented last week that we weren't practicing what we were preaching, and we had in mind the focus has always been the future of medical education and re-envisioning this. This is what I really believe is our obligation to benefit from, in many ways, this crisis that COVID-19 has placed us in, and to emerge from it better. So next week, what we're going to do is, in fact, flip the classroom. You're going to get, with the follow-up, not only the information and all of Tusi's handouts from this session, but you're also going to get some preparation, some homework for next week. What you derive from webinar 3 is going to be directly proportional to what you put into it. We're going to give you a number of resources to explore before the webinar, and the greater your depth and breadth of understanding will be contingent on how much time you can spend. So hopefully you'll dive in. But in any case, during the webinar, you can also take either an active role in discussing your vision of medical education of the future, or sharing what you've learned from your exploration, or you can just observe and listen. We're going to have breakout rooms. So as you come in, we'll have a brief introduction. We'll go over the construct. We will send people into breakout rooms. We will then convene and have discussion afterwards. So it's going to be highly interactive, and it'll be flipped. With that, do we want to, we'd love to, Stefan, do you want to see what questions have come up in the chat box? I see a big number there.
Absolutely, mainly comments rather than questions. So let me share briefly, since we couldn't do this survey, but we want to leverage the survey information. One of the questions we asked last week is what barriers are keeping you from trying the kind of changes that you want to make towards more evidence-based medical education. Let me just tell you the top four in terms of your votes. The number one was technical infrastructure. Certainly that's something that is a focus of our work in many ways, to make it easy for you to sort of, go in those directions. Then the next three, which were all fairly level, were change management. So the recognition that it's not easy to change, the ways of your stakeholders, even though right now you have some good reasons to argue that rapid change is needed because it's a necessity in many places when things are simply shut down. Time capacity for change management. So even if you understand change management, just recognizing that it is a lot of work. I'm sure a lot of you have a lot of experience with that over the years. And then finally, financial limitations, so can we put the things in place that we need there? So those were the things that you fed back last week, sorry. So in terms of some of the questions from this week, some of them were clarification questions, meaning of LAAT. I think that was already pointed out. Renee had a question specifically for your case, to see that you presented. I think that was probably referring to the table, what the time frame of that lesson was. Quite specific question. If you want to answer that briefly, then obviously you'd be welcome to. But I also want to invite people to unmute themselves and ask questions. Let me place one or two here though to get us going. There was one question, which is, how do you think the changes to pass, fail, and step one will affect medical education and third-party platforms? And it's interesting because obviously a lot of the market is focused on maximizing scores rather than building good doctors. And so it's a good question to ask. So this came from Ben Daines, and maybe Tusi, Peter, I think you both know that market somewhat. So Peter, go ahead.
I'd love to take that one on because I really think this and I'm staying in close touch with both my students at Ames and in many schools and Hopkins, as it's right here in town. And I think that was a move in the right direction away from grades. There's such an emphasis on these boards, and really isn't our endeavor to create an educational experience that gives you the knowledge so that you don't have this great pressure of having to review. And I think that's been one of our big endeavors with creating a comprehensive platform that really gets used from day one and maximizes the whole learning experience. I think if we change how students learn and how we educate, we can solve many of these issues. And there are products that will, technology will address this, but I think we will see an evolution away from sort of prep products. We know that cramming doesn't lead to long-term retention, and what we want is our physicians to learn it efficiently initially and retain that knowledge. But 2C is the expert. We need to design how we teach well to maximize the efficiency. That the sort of the analogy I had with industry and manufacturing. And we really need to apply some of these concepts to the educational process. So, Tusi, what are your thoughts?
My thoughts is that students are going to dictate what that change is going to do.
Well, absolutely, but I think if we make it easier,
I think people like Ben are going to determine what happens to learning platforms and learning resources in many respects, because after the change to pass fail, and I myself like to listen to what students and their impressions and their thoughts on the learning process, because they're smart. Especially medical students, I found. People like Ben are very, very smart in terms of how they're learning. They might not know all the skills that the physician has to have. Obviously, they're not there yet. They haven't developed those skills. They might not know what they don't know, but they certainly know how to learn and what time and efficiencies there are. So again, I think my answer to that question is going to come from the student's perspective. And I like to work with students to figure out that answer.
Mm-hmm.
You know,
And
I'd like to just jump in though and add one thing, and I completely agree. I think it's wonderful to have students not only interact on how they're taught, but also, you know, one of the great ways to learn is to produce, you know, is to teach the material and to help contribute to, you know, in an interactive way. The one caveat I found in my experiences is that there's this concept from the cognitive science of desirable difficulty. And there are students that want sort of to absorb knowledge. And certainly it was true for me. And it's the rare student that doesn't have to work to acquire and retain knowledge. It's an active process. And I think one of our endeavors in using technology is to make work fun. And that's what interaction does, doesn't it? So when we talk about gaming and like this interactive modality we created for the COVID-19 teaching, it is work, but it also makes it fun. So I think you're right, Tusi, and this goes right back to teams, instructional designers, faculty, students, and the folks, you know, Lecturio's software design and production expertise. No one group has it all, but you put all those elements together, and I think we're going to have a pretty neat future in the medical educational process.
So I'll add a brief thought before moving to two more questions, because they've been quite interesting and thoughtful, I thought. So on this change, you know, I think to my mind, it's an opportunity also for educators to say, okay, it's less focused on passing that exam and the score, and it frees us up a little bit maybe to teach more toward what makes a good doctor. Also from the selection for residency slots, obviously it was always the easy thing to do, to sort them all by scores, right? But in the end, I think you all know this in your practical lives, and the educators are usually the ones that are, you know, driven by the right motivation. Not all doctors have the same motivation. You know, some of them it's status and other reasons why they go into medicine. And if you don't have that score anymore, all of a sudden you're going to maybe have to emphasize a little more your leadership skills, your empathic, your communication skills, and other things to get that residency slot. And so I have some hope, at least, that it might give us better doctors in the long run. So, but there are two questions I want to bring up. One is from Nazar in Iraq. And Nazar, welcome for showing up so late, because you're one of the latest time zones we have present here. And I said, how would you insert the motivation of both students and teachers in your models? I think that's a very nice question, Tusi. I think you're the right man to address this to.
Yeah, what I like about Keller's ARCS model is it doesn't have just the 4 different constructs. It comes with a systematic process where you analyze the learner in terms of their perceived levels of attention, relevance, confidence, and satisfaction. And based on that measure, again, on that Yerkes inverted U, is it optimal? Is it less than optimal? Is it too much? And based on that analysis, the model also has very specific tactics for increasing attention, increasing relevance, increasing confidence, and satisfaction. That can be readily adapted to faculty to have them motivated to utilize student-centered approaches as well. So it's integrating the motivational design process, in my opinion, with a systematic instructional design process.
And I like to jump in just from a practical experience, because frankly, this has been my endeavor for over a decade now, is to bring sort of these concepts into to introduce them to faculty and students that haven't been used to it. And I would encourage everybody to add two factors, and one is patience and the other is perseverance. You know, change never happens quickly, and if you're patient and you persevere, you will succeed.
Thank you. And now there was a specific question also around the key difference between problem-based learning and an integrated curriculum. And that might be a useful thing to take apart. And Peter, I'm sure you'd be able to do that, but either of you feel free to contribute.
Yeah, go ahead, 2C, because you've broken it down if you like.
Well, in my opinion, problem-based learning there doesn't have to be patient-centered or it doesn't have to be case-based. They're different problems. So you could revolve around a whole bunch of problems. But, and you know, I think the way to think about that question is to basically say almost all student-centered active learning strategies present the learner with an authentic challenge. And that's the key. Here is something authentic that you're going to do in real life. Now, learn the facts, learn the concepts, learn the principles within the context in which they will be used. And that fundamentally is true for almost all active student-centered instructional approaches. And I think that's really the lesson learned, is not necessarily try to dissect the difference between all these approaches. All these different approaches that you've seen that I've included in that handout is derived from the fact that most faculty have to publish. So they're just changing some aspect in a little way. And, you know, there's advances in different things. I've done the same thing, is add different concepts, but I think the fundamental principles are what's important.
And so I would just reiterate to that from a practical standpoint, and this is what we try to emphasize today, is interactivity is absolutely crucial. And then as Tusi said, you know, I like to think of it as concrete examples. And frankly, when you have cases or problems, and this all feeds into what Tusi described in terms of motivating the students. So exactly as he says, it's these sort of emotional components, these engagements that really are what make the learning stick, if you would.
Great. I'll add my own very brief version, you know, to the way I understand it, at least the integrated curriculum attempts to link up the basic sciences with the clinical application rather than sort of leave that till later, you know, do it earlier on. And PBL, obviously, very specific way of teaching, you know, any kind of subject for that matter. If you have additional questions, feel free to unmute yourself and speak. You can show yourselves here. This is quite, you know, powerful tool, Zoom, in terms of the capabilities. And Tusi, you have an addition there. Go ahead, please.
Yeah, can I address a specific question posed by Carrie Kelly? I'm just looking at the chat. She asked for specific examples of ways to teach the clinical skills. I think that's on the mind of many clinical educators right now, considering the limitations with clerkships and internships and residencies. So I would actually turn that around to Kelly and say, Kelly, what aspects of clinical skills, what fundamentals can you teach online? So kind of using some of the basic principles of what's stable, what's some of the lower order skills and knowledge, what aspects of clinical reasoning or the diagnosis and treatment of a patient can you teach that's fundamental and do it well online? And then what skills have to have really synchronous interactions? And I think one of the things I learned about 20 years ago, I was actually putting a clinical laboratory science curriculum online, is that one of the problems is when faculty feel that the interactions, the synchronous interactions that have to occur with him or her. And egos get involved. I'm the expert, the interaction has to come from me. If you're an expert, you should be able to design these interactions to occur in remote locations. So as an instructional designer, I would work with experts like Peter and experts like many of the faculty here today and say, okay, what are the key aspects of that clinical experience? How can we design them so students in remote locations can have that experience without you there?
And
I know that's a hard pill to take sometimes, but again, an important thing if we want to make learning accessible. And that's part of being an expert, in my opinion, is how do we teach people how to do these things without necessarily you having to be there. But you're there in terms of defining criteria, procedures, making sure the assessment is valid and reliable, but then using instructional design so people can use it in many locations. Does that help, Carrie?
Yeah,
Yeah.
and if I can add to that, because I have direct experience, you know, when we had our online program in the South Pacific, there was a lot of sort of remote learning, and this is 12 years ago. And I'll add parenthetically that we have for the osteopathic group, there's a lot of physical examination on our platform. We're adding now a physical diagnosis lecture series where you demonstrate it, but then you can interactively work with your students as they practice. So as you said, there's a synchronous and an asynchronous component. And much like the flipped classroom, if you have the resources available so that you can, for example, they're asking, you know, an otoscopic exam, you can see these things well. We've added 3D imagery to our anatomy lectures. And from my standpoint, remember, I'm a general and then cardiothoracic surgeon. I find it easier to understand anatomic relationships in a 3D model that you can manipulate rather than a desiccated formaldehyde preserved cadaver, and many of which have been pre-dissected. So I think as we move forward to the future, we learn, you know, what modalities technology can actually augment, and never do we displace the teacher, but you put what you use the technology features to demonstrate pathology or normals, and then you engage the students interactively as they learn in the process. So I think all these things are very achievable. We're actually working, our next project will be to characterize the entrustable professional activities, what are required in the US or expected for students finishing med school and go to residency. And these are challenging things, but I think we'll be able to capture the essence of this in a platform modality, and then much as we've just talked about, we'll flip the classroom and assure competency. One of the things I think we'll touch on in the next session is how do you assure competency-based progression? And that, to me, is really the future and the holy grail, so that students don't have to progress in a lockstep fashion, but when we've demonstrated that they've achieved a certain level of competency. And that, I think, will only be possible, you know, once we've all adopted a platform-based approach.
Carrie, go ahead. I know it's hard to get a word in, so.
No, I just was going to say thank you. I think the question with the otoscopic exam is kind of the biggest thing, you know, not even just kind of knowing the anatomy, but like just even how much pressure to apply, like kind of how to, I mean, when we're forced to do things virtually, I guess it's hard to know when we're going to be back virtual or full or fully in class or not. And so kind of knowing how to do that if it happens to happen when we were kind of planning to do that part of the clinical skills. I hope what I'm saying makes sense, but
yeah, it does. You know what I'd encourage you though, and really the reason for this webinar is not so much to help people right now. You know, we're in a very unique time in history, but to really encourage everybody to focus on what could be better that we wouldn't want to change, you know, presuming we have a vaccine and COVID-19, you know, disappears, and who knows whether it will or won't, but I think we feel optimistic that it will. But let's take this opportunity, so not just figure out what to do now, but figure out what would be good, you know, absent COVID-19. And I'm convinced the reason I've moved out of heart surgery and into this area is I believe, you know, there's so many advantages to fundamentally changing what we do. I don't know if you were in the first webinar, but I've been preaching this, and I still will always remember the faculty member at Ames that, you know, sort of jokingly asked if I unleashed COVID-19 just to, you know, to force this all to happen. So, you know, it's obviously a tragic situation for many, but that's the task at hand. Find all the things, how we can make this better. And because I think we do need to educate people more effectively, efficiently, less expensively, and more widely.
Yeah, and I'm fortunate to work at a place where we do a lot of the flipped classroom already, so that's good. And this has been really informative and helpful. So thank you guys so much.
Yeah, no, and we hope to have it a continuing, I hope you come back and we for next week, we have our flipped classroom approach, and we have tried to build Lecturio as a community of educators. There's a big contributing faculty of interested people, and not everybody in medicine needs to be interested in teaching. But those of us that are, I think can create a new paradigm that then is shared widely and makes it better for everybody.
So real quick, I know that we're kind of running over time, but I do really want to directly answer Carrie's question, as well as Diana, I believe, Diana Weber. She followed up with the otoscopic exam question. And I think that's very important to answer and address very honestly. And I think experts understand the limitations. And as a design expert, I don't believe you could teach certain things online. And we have to recognize that. We could facilitate and again, design experiences where the student may go to a remote laboratory or maybe even do something in their house, depending on what the skill is. But again, it's the bottom line is coming up with valid and reliable assessments. So if an expert can come up with valid and reliable assessments and say, okay, now go to a clinic, go someplace that is open, maybe go out to the park and do X, Y, and Z, and then have somebody like your mother or father or spouse evaluate you with these valid and reliable instruments, assessment instruments and checklists. Maybe that's the best we can do at this point until we come up with simulations that actually teach these kinesthetic skills and are sensitive. And they are being developed. I mean, there are simulations out there that does have the touch and feel of surgery and all that kind of stuff, but they're not pervasive. But again, I think the bottom line for me is, not everything can be done this way. What we have to do is find out workarounds. So that's my answer.
Yeah, and I'd add to that to see that in my experience, even the online program in the South Pacific was always combined with students having relationships with physicians. They were spread around the world, but they had relationships with physicians, clinics. There was a real touch and feel. So I have, at least for now and for the foreseeable future, have always combined a technologically augmented approach to the didactics, the knowledge base, but with real life experiences. We have to, we are in people business, and you need to deal with people directly to learn those skills.
So just one brief addition here, Carrie. I also sent you an email since you asked another question around what's covered and so on. My colleague Rosie, who's also on this call, will be happy to show you. And it's interesting because I was having a demonstration of the simulation part just earlier today, and the question was asked, can I do, palpation of the abdomen and things like that? I said, yes, you can, but do I get pressure feedback and things like that, And the distinction I would make is, I guess there will be things where we conclude that there are new things that are just more effective for the long run. This is probably not one of them, right? Eventually you want someone to physically and have someone to give you physical feedback, but it might also be helpful to think about, how can I explain this better? So is it like, if you're pressing an orange in the supermarket and checking how hard it is, that's already too hard, So how hard do you want to press? Think about, you've got a leaf on your desk and you would have just trying to gently push that down till you get a resistance. That's how you want to be doing it. So, let's do the best we can with the constraints that we have, recognizing that in some areas, what we're doing, we'll be happily and quickly replacing with the real thing again. But at the same time, I think there are some opportunities where we will be surprised just how much is possible to do digitally. And for me, it's interesting, I mentioned this during the last call, interesting to have these gatherings here, for example. Now, you know, we can look at people's faces more closely than if we're in a lecture hall. So if someone looks tired or looks stressed or looks disinterested or whatever, we can sort of potentially address that more easily than in the traditional face-to-face. And you'll be seeing next week, I don't know if you have experienced it, but I recently did a sort of a large 350 people seminar with breakout groups in Zoom. And I was just amazed how quick and easy that was. So if you haven't done this yet, maybe you have, and some of you will not have, you know, all of a sudden, you know, who would have, you know, 50 breakout rooms ready in their classroom and be able to send people there in 10 minutes? You wouldn't be able to do that. You know, all of a sudden digitally, you can do certain things that weren't possible before. So let's sort of try and capture all of those advantages that we do have, while obviously, you know, we're recognizing there are those limitations, and we'll have to do the best we can with them for a while, potentially.
No, thank you guys. That was perfect. Perfect answer. Thank you so much.
Thanks so much.
Appreciate your joining us. There is a question here about osteopathic, you know, elaborating work with osteopathic schools, and we've actually got Dr. Tyler Sinnott is a senior osteopathic professor, has added at Stefan, how many hours? It's a very substantial.
The full curriculum, full osteopathic curriculum. So we have hundreds of videos on the osteopathic.
Hundreds of videos, right? It's very
demonstrations of assessments and where to press and what to do and so on. They're different production effort than these lecture formats.
Exactly. And if you email us, and did we give the email for direct inquiries?
You can just send us an email at institutions@lecturio.com.
Exactly.
It's the simplest. I posted here as well. But you'll all be getting the follow-up email to this anyhow. And Dr. Sheld Yahoo is the other instructor. Thank you, Rosie, for reminding us of that. And on the osteopathic front, and institutions@lecturio.com. I'll just send that email here. But all of you are in any case going to get the handouts we discussed by email. You'll be getting those from my email. So feel free to respond to that if you have any queries and questions, and I'll be happy to make sure they get answered and someone gets back to you. And obviously we'll have the chance next week to also review some of the questions that might have come up before. So. Good. If anyone else has questions, feel free to unmute yourself and ask a question or write it in the chat. Feedback welcome as well, whatever you want to share. Good. Well, if everyone is satisfied and saturated for today, certainly in terms of educational models, I think I've not been able to process all of them for sure, but it's made me curious to sort of, you know, spend some time going through and taking some inspiration and so on and so forth. And it's always great to have somebody like Tusi to turn to explain and think through how can this look in practice and what have you. So let me thank you, all of you, for your attention, for your engagement. We're by now, I haven't even checked the time, 24 minutes over. We have people in time zones where I think it might be approaching midnight or later. So it just shows the level of engagement and interest and the care. For me, I must say, it's always one thing I remind myself of is working with medical educators is a real privilege, because, you know, a lot of people become clinicians to care, and then those that become educators tend to be a subgroup that tend to care even more. So usually they're fun people to hang out with, and you have been, and we look forward to hopefully hanging out with you again next week. And we hope it was stimulating and helpful for you today. Feel free to unmute yourself and wave. We'll do that.
Hi, thank you for all presentations.
Thank you. You're welcome.
Hi, guys.
So that's good.